Welcome to Three Black Docs. Our second happy hour is here. It's Friday evening. Thanks for coming to hang with us. It's time for me to get my drink. Why don't you grab yours and let's get into it? All right, so I'm here again with the other two of the Three Black Docs, Dr. Z, otherwise known as Dr. Zanetta Lamar. Say hi to the people and tell us what you're drinking.
Hello. So, I usually have my water on the rocks. My ice machine is broken. So, so my rocks are gone. My rocks are gone.
Wow.
So I have my Costco cup.
She basic.
Water straight up. I'm gonna need you to get your ice maker fixed.
I know.
Summertime.
I'm gonna have to get it fixed.
I don't know that out there. Okay, and last but not least, Dr. Karen Winkfield. What you drinking tonight, Karen?
Well, tonight I have a special ice cube. You see this? So I have my child actually made me these special ice balls, and I'm just using that with my salted caramel.
I've seen that before.
Lovely.
There's some sort of science behind
that. It's really big, yeah.
Yes.
In a drink.
And it doesn't melt?
Yes. Well, with whiskey, it actually melts differently and it tempers. I don't know all the science behind it, but yeah.
You got fancy ice.
Fancy tonight.
And some of us need some ice.
So we have fancy ice and no ice. And that's our situation.
It's so funny.
Right now.
Awesome. So what are we talking about tonight?
Well, first I got to tell you what I'm drinking. Dun, dun, dun. I saved it because you're going to be shocked, Karen. I'm drinking a beer.
A what? Come on. You? Beer?
I don't think you've ever seen me drink a beer. It's summertime. And in the summertime, I really there's a beer called Summer Shandy. And it has lemon flavor and maybe some honey, and it's really light and delicious in the summer.
Awesome.
So we got a summer theme. We have ice issues, fancy ice, and Summer Shandy beers. All right, what are we talking about tonight? Prostate cancer.
Yes.
Ta-da! So, and here's why.
You sounded excited about that.
I did, didn't I?
Like me talking about colonoscopies.
I know. It came out. I'm excited. I'm excited to talk about it. Our people need to know about it.
Share with us your excitement, Z.
Well,
why are you excited to talk about it?
Why am I excited? Excited may be the wrong emotion.
Strong.
But I said it may be the wrong emotion, but our community is being devastated by prostate cancer. And we need our people to know about it. And there's information that honestly, I think a lot of physicians are not aware of. And so I think this is a really important discussion.
For sure. So it is the most common cancer amongst Black men. Black men are actually more likely to contract prostate cancer, to develop prostate cancer, than white men. And last year, in 2019, there was an estimate of 29,000 new cases in Black men. So
it's a big deal. It's a big deal. It's the second leading cause of cancer death.
Second leading cause of cancer death in Black men. Lung cancer being the first, along with women. But and so again, there's an issue of seeing that the numbers are different in Black men. And so we're going to get into why and what to do about that. But the other thing that I really want to put out there right off the bat is, even though the numbers are worse and that Black men are more likely to contract it, if it's caught at an early stage, 97% of men are alive at 5 years. 97%. Okay. So this is all about knowing what the facts are, knowing what the risks are, right? And knowing what you need to do now that you know. When you know better, we can do better, right?
So we can do better.
So
and there was some intentionality around theme too,
Right.
though, right? Because part
It
of it
is.
was, we just came off a Men's Health Week, right?
Right.
Yeah.
We also it was Father's Day, so hopefully this is not just something for men. We need for our women to be engaged as well and to understand the challenges that our men may face, the barriers, and really so that we as a community can work on this epidemic. We are dealing with the pandemic of COVID, and we see how that's devastating the Black community. Prostate cancer is devastating our Black men, and so we need to figure out how we can really address that. So there was some intention around why we're speaking about this now.
Um, and that's a good point, Karen, because I think a lot of it, not to shade our men, but a lot of times it's the women who are on top of going to the doctor and making sure our screening stuff is right, being good about mammograms and pap smears and all that stuff. Maybe add colonoscopy to the list if you listen to the last podcast. And so I
Yes.
think that the women having this information too and making sure that the men in their lives are aware and up to date is very important. So,
Right. And I think as a healthcare community, we have done a very poor job of getting the word out, especially as it pertains to Black men and
Yeah.
what we should be doing and what we should be telling them. Because I mean, there are different societies that are saying different things. And
Yes.
if you are a family physician seeing 20 to 30 patients a day, it's hard to keep up with what to tell people. So
Yeah.
I,
Around screening in particular,
around
right?
yeah,
screening particularly.
Yeah.
yeah,
Yeah.
So
And and
let's
and,
get
and
into
it's
it.
funny because again, our last podcast that dropped was on colorectal cancer, right? And
Right.
colonoscopy as screening. And I feel like the guidelines are pretty clear, right? As
Very
you
clear.
mentioned, there may be different organizations who say, American Cancer Society says screening this time. It's not the case for prostate cancer. And
It's
so that's where a
right.
lot of the confusion lies. It's not even just the primary care doctors that are confused, it's the population, the public who's confused. And I think that's why this discussion is really important as well.
Right.
yeah. And Zanette and I were talking about this. It's kind of an interesting position to be in as an oncologist, right? Because our focus is like what happens after you get diagnosed,
Yeah.
right?
Right.
Yeah.
And so that's what we learn about and have to know about and get tested on and all that stuff. And that's what our day-to-day
Mhm.
life is like what happens after you get the diagnosis. We need to be on top of it and making sure we know all the up-to-date information about the best treatment. But really, I mean, to me, the power is in that first number that like if this
Yeah.
is diagnosed early and caught early, that's, 97% of people are alive at 5 years. So really to me, the battle is there, right? In knowing when to screen and being on top of it and, catching it early if we need to catch it. So with that
Well,
being
I
said,
think, and I don't
go
know if
ahead.
you talked about the specific disparities that exist for Black men. I know you
I was
mentioned that they
just
get it
about
more.
to say, with that being said,
Okay.
let's get into why we have this disparity of Black men. So take it away.
Me?
Yeah, you.
All right.
You
So,
brought it
so,
up.
well, I know, but I kind of
You're
got
it. You're
interrupted
it.
there, so I wasn't sure. Like,
Mm-mm.
but
No.
part of it, I think, it is really critical. Yes, Black men get it more, but to what extent, right? They're almost twice as likely as white men to
Twice as
actually
likely.
have prostate cancer, and then twice as likely to die of prostate
Mhm.
cancer. So what that means then is number one, there may be something biologic, there may be some environmental things that are going on, but to what Zanetta was just saying about the importance of screening, and this is why we have got to have the conversation about what is the appropriate screening, when do we start. Black men are presenting with later stage disease, and it's much easier to cure any cancer early on. And so late stage disease makes it harder to treat. And, particularly when you end up with metastatic disease, then you're dealing with a lot of issues. My uncle died of prostate cancer. I don't know if any of you if either of you
Yeah.
have had family
Oh
Yes.
members that
yeah.
had prostate
Absolutely.
cancer. And
Yeah.
Mhm.
it's devastating when you have bone disease, when you have, metastatic disease that goes to the bone, that's really hard. So the earlier we catch it, more likely the chance that you can cure it.
Yeah, I don't think there would be anyone who's like listening or will listen to this that doesn't know somebody personally or know of someone, that's had prostate cancer or has been affected by it.
I don't know.
I
My
really
uncle was the first person in my family who actually had prostate cancer. So that was I was surprised by that too because of how common it is. But the challenge is
Mhm.
I don't know if my family members are getting
Well,
tested or screened
and
for
that's the
prostate
thing.
cancer.
It's something that you really don't talk about. So,
Yes.
one of the first people that I knew who had prostate cancer was actually my husband's cousin. And when I met him, they said, oh, he has prostate cancer and it's really, really bad. And I met him. He was tall, he was handsome. There was nothing that looked like this man was ill. And I was like, oh, he has prostate cancer? And, a few months later, unfortunately, like he died. And
Wow.
and and you could not tell. So I think this is something that men are not discussing. It's not something that necessarily you can see. The symptoms are not something on the outside. And really, I mean, this kind of goes into the risk. And I think Tiffany, you were going to bring that
Yes.
up.
Yeah, no. Go ahead.
But the risk is higher in people who have a first degree family member who is affected. So, most importantly, if you have a brother who has prostate cancer, your risk is high. If you are Black, your risk is high. And really, it's important for us to talk as families and to say, hey, you know what? What medical problems do you have? We have got
Mm,
to do that as a
yeah.
community. We
Well,
have
but
got to
not
do
not
that.
just your brother, your father, your brother,
Right,
your son.
right,
If there
right.
are multiple people on one
Right,
side of the family,
right. The risk is
you know,
highest
Yeah.
though if it's your brother,
yes.
Mhm.
But
right? And
you
so,
have
So
but
to
also,
know.
but don't, like Tiffany said, anyone in your family who has this disease, it puts you at risk. And honestly,
yeah,
even if you don't have a brother, father, son, if you are Black, you have a high risk for developing prostate cancer. I
yeah.
mean,
So So part of I think the reason why it doesn't get discussed is because folk don't know where the prostate is. And can I tell
let's
you, I
talk
was
about
going to
that.
go to my office today and
Really?
pick up a model because I do my community engagement work, right? And
Yeah.
Yeah.
so I actually have a model of like the male pelvis that I was going to bring, and
Did
I
you bring it?
totally forgot because it would
Oh.
have been funny too, right? I'd have been like, what? So anyway,
No,
it would have been
I would have
yes,
been surprised if
yes.
you had
I
broken
know
that
you would
out,
have, but
but mhm.
our people,
But
our
you
viewers
should.
would have been like,
Yeah, let's
oh,
talk about where the prostate is.
right.
And what, yeah.
Because, and it's called a prostate, not a prostrate. And prostrate means lying down flat. Prostate is an organ. So we can talk about what that is. But it actually lies at for a man, only men have it, right? So it lies at the base of the penis, right? At the base of the bladder. So, the bladder is the collection vehicle for the urine. And, in men, their ureter is external to their body. So it's outside of their body versus women where it's internal, right? And the ureter for men travels to the penis. And so if you
And
track
the
the
ureter
the
is the tube that connects the
the
kidneys to the bladder. It's the tube that puts your urine in your bladder.
Yes, so your urethra is what I meant to say. Sorry, not the ureter.
Right.
So and urethral. Uh,
Urethra.
bottom line, this organ sits right there at the base of the bladder, and the reason why that's important is because the physical exam for the prostate actually goes to the rectum, and you can literally feel the prostate because it's lying that low in the pelvis. So it is an organ. It actually helps to create the fluid that comes out with a sperm when a man is
Right.
having sex and he ejaculates. It actually creates the fluid, which is an important part of getting those, the sperm to where they need to go for conception. So that's what the prostate does, and it's important. Um, but I think it's important for us to make sure that we know the anatomy and know what it's called, so we can have discussions with our
Right.
doctors about it.
And often if you can have cancer and actually not have symptoms,
Hmm.
and that's the thing that can be tricky.
Hmm.
You
Mhm.
may not have, some people, once it's advanced, you may have symptoms like with blood or, difficulty with urination. But one of the problems we have is that sometimes, early on, you may not have symptoms.
Yep. Yep. And that, again, a lot of it's because of location, 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 right? Versus a cancer in
Exactly.
your neck where you're going to see it, or a cancer in your mouth where you might feel it. This prostate, because it is so deep in the pelvis, is not something that may oftentimes have symptoms associated with it. So, yeah.
Mhm. Yep.
Right. And
Yes.
and one of the things that I actually didn't know, in Black men, sometimes prostate cancer is not located in an area that's easy to feel with the digital rectal exam. So
Right.
digital rectal exam, that's when a doctor uses a gloved finger and you can typically feel the prostate. But often in Black men, the location can be in a space that you may not be able to feel. So, I mean, this can be an issue when it comes specifically to Black men and screening and diagnosing
Mm-hmm.
potential
And it's
cancer.
not even about that they can't feel it. It's not exactly an area that oftentimes can be biopsied easily, right? So the
Right.
anterior
Exactly.
lobe of the prostate is what you're
Yep.
referring to.
Anterior.
So when they
Yep.
Yep.
typically go in, so say
Yep.
a man's going, remember screening is in addition to the digital rectal exam, which Dr. Lamar just lovely explained, gloved finger, yes, goes
Gloved.
into the rectum to feel the, yes,
Gloved.
goes into the rectum. You like my finger? Goes in and palpates the prostate. There's also a blood test, right? So that prostate specific antigen is a test that can be elevated for several reasons, but it usually is only is elevated for men who may have enlarged prostates or who have
Mm-hmm.
prostate cancer. And so if it's enlarged and you're like, okay, we're going to check for prostate cancer, but the typical biopsies that are done are around the other lobes, and that anterior, that medial lobe may not necessarily be able to be reached with the standard approach to biopsy. So that's important
Right.
too.
Right.
Now, one thing about we're talking about, digital rectal exams and screening. So one thing to note as well when we get into talking about screening is that you can have a screening with just a blood test,
Right.
with just a PSA. Okay. And so a lot of times men shy away, I think, from bringing this up at the doctor because they want to avoid the rectal exam. But you can at least get your PSA done, as a starting
Hmm.
place to screening. So that's something very important as well. Like,
Yeah.
don't
So
completely write this off because you
yeah.
are trying to avoid getting a rectal exam.
And I need to ask a question about the rectal exam because, it's been a while since I've been in medical school. Um,
Okay.
I felt like there were some challenges with people even learning how to do the digital rectal exam properly. Tell me what
Yes.
your experience has been for you guys.
So, it can and some it often it's how you're taught.
Yes.
And honestly, sometimes the size of your finger can make a difference.
Yeah.
Well,
Yeah.
with the rectal exam, and I don't think many people who are training today have learned to properly do the digital rectal
Yeah.
exam.
Yeah.
Um, so
I just was checking because
when you have felt an abnormal prostate, you will remember it forever.
yes, forever. And I learned techniques. I had an old school doc when I was at Duke who actually taught me techniques. I have very short fingers. My fingers are very short, but I tell you, I can feel a prostate, and I can feel that superior edge of the prostate because I learned some techniques about how to get in there and get it done. So I think, to Tiffany's point, I think what's really important to remember is that there are multiple things that can be part of the screening for prostate cancer. And even if somebody says, oh, I felt your prostate feels fine, if you're concerned about it, whatever, talking about, making sure that you're getting that prostate specific antigen, that test, that PSA test is a really important component of kind of really monitoring and looking at, it's really more prognostic, meaning what might be the risk of you developing prostate cancer. Because frankly, there are some cutoffs for that PSA test, right? If you're a 40-year-old Black man, if you're a 45-year-old Black man, there are some cutoffs for that test that may actually be prognostic. And that was some of the work that we were doing when I was in Boston
Yeah.
with some of the groups there, looking at not only just as a screening tool, because again, there are other things that can elevate that PSA, but what are the
Hmm.
things that may actually be able to say that this person's risk of developing prostate cancer is higher than the average person?
Hmm.
Right. And so now let's actually talk about age. Because in our there are national guidelines. If you look up online, there are different ages that
Mm,
that we tell people to screen for prostate cancer. I know
Right.
my age and I know the rationale for why. So,
mhm.
Well,
Tiffany, do you want
okay.
to get
So the
into that?
first thing is to know that there are different organizations that put out guidelines for cancer screening, right? So prostate is no different. So if you just go on Google and say, like, when should I start PSA screening? You might get a guideline from any one of a number of different societies,
Mhm.
and they all have different ages. So let's get into that and let's get into why. So one of the largest ones that you will come across when you get into prevention and screening guidelines is the U.S. Preventative Service Task Force, USPSTF, is one. Okay, the ACS, which is the American Cancer Society, is the other. So those are like two big societies that you're always going to find screening guidelines coming from. Okay. For prostate cancer, there's also the AUA, which is the American Urologic Association. And
so what age should we say?
I'm getting into I'm just telling people that there are different societies that
give me a
publish
number.
different guidelines, right?
Right.
And so that's why it's important, because in a minute we'll talk about how the ages are different and how things differ, so that if
why aren't we there yet? Where are we going? What the heck? I'm sorry, Tiff, go ahead.
Y'all busting up my happy vibe.
I know it.
Can I live?
Give us.
Can I live?
Okay, folks asking questions.
And then the
we had Charlize.
We can't keep them waiting. We cannot keep them waiting.
Charlize is an actual comprehensive cancer center collection. Hey, Charlize. All right, so she asked the question we're getting into. So number one, if you look at the United States Preventive Service Task Force, their guideline is 55.
40.
No, their guideline is 55.
No, I'm saying this is the age men should.
Starting with this for a reason. Their guideline is 55.
Help us, people.
But
help us.
If you were okay, I'm sorry. Keep going.
They don't take into account Black men's higher risk. So all I was trying to get to, if y'all would let me get to it, is that the other guidelines actually do take into account the fact that Black men have a higher risk. And so this is why we need to know this stuff about our own cancer risk, our individual cancer risk. Okay, so
yes.
That's one.
And what I've noticed is that
and see 55, and that would be wrong if you were Black.
Okay.
The answer is 40.
Zanetta.
Right? If you 40.
Go ahead, Zanetta.
No, if you are Black, you are high risk. You should get your first PSA at 40. When women are getting their mammograms, you need to be getting a PSA. Because you're high, it's high risk. It's 40. And the reason why you need to start early, you need a baseline. Because the problem is Black men, sometimes their PSAs are lower. And you need to know what your baseline is and check every year and see if there are trends going up. Because I mean, we already talked about that. Go on, Karen. Karen's.
No.
The location. Of disease may be different. The PSA levels may be different. So it's really important to have a history of PSA levels. Sorry.
And I agree with that 100%. And the only reason why I wanted to backtrack a little, because Tiffany went through a whole litany of talking about the different guidelines that there are. And in fact, the guidelines change all the time.
They just change.
That's what part of the challenge is. But they just change. And so all of them are using this 55 as the cutoff, except the American Cancer Society, which is at 45, including for Black men, unless you're a Black man who has family history, and then it's 40. So, but I tell people all the time, them guidelines are not made for Black people. I say
they
that
are
all the
absolutely
time.
not.
And if you look at the
point I was trying to make,
that they're using to make those recommendations, they include fewer than 5% Black men. So we weren't even part of the calculus. And so it's really important, again, to Zanetta's point, I do recommend that for Black men, they at least have a conversation with their doctor starting at age 40. And they can insist, like a blood test. Look, you don't want to feel my rectum. I mean, you feel my prostate.
Blood test.
Good.
Blood test.
Give me a blood test.
Get the blood test. Because let me tell you something. Once again, the stuff that we go through, if I didn't have to have a mammogram, a pelvic exam for pap smears and all that stuff, and you said you could just draw my blood and my cancer screening would be done, sign me up. I mean, come on.
Right.
You don't have colonoscopy prep. You know, you don't have anything getting smashed in a machine. You don't know about that yet, Zanetta, but you will. You know what I mean? No, she's not 40 yet.
Lord, I'm dealing
Karen,
with
you know that next year.
Baby.
Y'all are cougars. No, I'm just
but that's the point. It's super. Call me a cougar. It's super easy compared to other screening tests to get the blood test, right?
No, it really is. It really is, and it's so important. All right,
Yeah.
Tiffany.
Yeah.
So that's what I was getting to, was just that, the guidelines, one of them doesn't take into account the higher risk of Black men, right? So if you just go to Dr. Google and find the wrong thing, you out here in
Yep.
these streets thinking you good till you 55, which is just not right if you're a Black man, period.
That's right.
It's just not right.
That's right.
ACS is 40 if you have a first degree relative. And the AUA actually just says from 40 to 54 to have your first conversation if you're a Black man. And for everyone else, they start at 55 for average risk.
So for Black men.
For average risk men.
Yeah.
But
Tiff, your mic is doing something weird.
is it? Can you hear me?
It's okay. Go ahead.
You can hear me? Okay.
I can hear you.
So you brought up a good point, Karen, and that was that in the largest screening study, there were only 4% of Black men. So this is an issue about, yes.
All right, sister-in-law.
Oh, okay. All right. Hayes, another sister-in-law. Yes. Oh, Lamar, I should have caught that. 4%. Okay, in a prostate screening study.
Ridiculous.
So I'm speechless. I'm without speech.
Yeah.
So let's talk about the need. Not for too long. Let's talk about the need for getting Black people into clinical trials. Where the barriers are on our end in the medical field, on the end of just being a Black person that wants the best care and wants to participate. Because this is what you get, right? You got a cancer we're talking about that disproportionately impacts Black men enough that some of the screening guidelines are different if you're Black. And we got we have a 4% rate in the clinical trials, which had like 80,000 people. PS.
Yes.
For screening.
Yeah.
So
yeah. I mean, it's the same thing with women with breast cancer too, right? A lot of those trials that were done to talk about screening, age of screening, et cetera, the screening studies had, fewer than 5% Black women as well. So it's to Ms. Lamar's remark, we are always left out. And there are some institutional and systemic reasons why, but I think a big part too is that there's fear, like in our community. I did some work when I was in Boston around perceptions of clinical trials and cancer among Black populations. And, there are folks who are just a little bit leery of the medical system. It was with right, and look, there's been some horrific things that have happened to Black and brown people in this country, that have been held by the medical system. We talked about that in one of our earlier podcasts, right? So we talked about these things. Even some members who don't want to necessarily get trainings or get what is that called when you go and get the flu shot?
Vaccines.
So there is some of it. I think that oftentimes the clinical trials may not be done where we are getting care.
Right. Sometimes in our communities, you just
right.
There's not the access. Yeah. So I think it's important getting men in the door, and I think that's why that 40 number is really so important. That you have got to go and see your doctor early on. And so, you there, Karen?
Yes.
Okay. So, if you don't have clinical trials in your area, what kinds of things would you, tell Black men? How can we improve the disparities if maybe you don't have access to those trials?
Yeah, I'm sorry. I'm having trouble with my head.
Okay.
Some noise, but I think your question was, what can you do if there aren't clinical trials in your area, right? Studies can actually be accessed, national databases, et cetera, things like that. I think, again, we've got to work as a community to say what's important to us, and in some ways demand that some of these research studies come into our community. Greater and greater bring clinical trials into the community, but there has to be willingness to do that. So, for instance, one of the studies that I was working on when I was in Boston was developing a project around Black men that would incorporate racially concordant navigation so that they could have an individual who looks like them. So a Black person
Exactly.
who understands
That's
prostate cancer
Aisha,
screening,
my
you
co-resident.
know, and all right. So the person would be seated within the working actually at a community clinic um, and provide information. Just telling me I can't be heard. So I'm going to block
Yeah.
off and I'm going to get
So
Yeah,
let's
continue. Okay.
talk some more.
I have something to say though
Oh,
while
okay.
Karen gets her audio together because I saw. Did you say that was your co-resident?
Yeah.
Somebody you did
Yeah.
residency with? Yeah, that talked about needing more faces that look like ours. So I 100% agree with that. Now we're getting echoes, Karen, from your end. Okay. Um, on the other hand, there's a lot of work to do in our families because I can tell you in our community because I can tell you that there was not uncommonly it would happen that I would talk to a patient about enrolling in a clinical trial, like when they were in the office and they were wanting to participate, and then they went home, and then they would come back and they would say somebody in their family, insert a name, told them, don't let them make you a guinea pig.
Right.
Don't sign up for this. And then that was kind of it, and so it goes to, I think, what Karen was getting to, and what we will talk about more so as our podcasts go along, is that we need to talk about what's going on in our communities and how really being left out and not having participation in trials, either because they're not where we can participate or that we are so still there's a lot of trust issues, which rightfully so, but at some point we have to get the numbers up,
Right. Right.
so
So also just talking more about just prostate cancer in general. So we talked
mhm,
about the age. 40, you need to start your screening. You really should get a PSA at 40 and honestly just about every year thereafter. So you've been screened, your PSA may be abnormal, or maybe you had a doctor who was comfortable doing a rectal exam and or something was abnormal, you have a biopsy and it looks like it may show prostate cancer. Like, what happens next? What would people expect? So
well,
one thing, oh, go
oh,
on.
go ahead. Go
Yeah,
ahead.
yeah, yeah. Yeah, I was going to say one thing that's also important in prostate cancer is not only the PSA, but there's also something called your Gleason score.
Mhm.
And so this is a score that we use to kind of determine the aggressiveness of the prostate cancer. And if you are diagnosed with prostate cancer, the one thing you always want to know is, what is my Gleason score? Because that plus your PSA and some other things puts you in a certain risk criteria. And after that, you determine what kind of treatment may be available for you or whether or not you should be treated at all. So this is
Right.
another big controversial
Yeah.
area that is very confusing,
Mhm.
very fragmented in prostate cancer.
Yep.
And that is, how do we know who to go to if we need treatment for prostate cancer? And how can we determine where to go?
So, and one of the things that I think is really important, some centers do this well, where they actually have different practitioners, right? They may have a urologist who is the type of surgeon who works in the pelvis, right? Urology doctor. And they'll have a radiation oncologist, someone who uses radiation, because these are all treatments that can be used upfront in the upfront setting for local, like prostate cancer. Medical oncology tends to be not necessarily included early on, except for intermediate risk, where there may be some hormone treatments, and we can talk a little bit about that in a minute. But I do think it's important for any time there's a diagnosis of prostate cancer for individual to at least have an opinion from a surgeon, urologist, and a radiation oncologist, at least.
Could you
And some,
repeat that? Because that is so important.
Yeah.
One more time.
So again, anytime a man is diagnosed with prostate cancer, I don't care what stage it is, it needs to at least have a visit with a surgeon and with a radiation oncologist at least. So those two different specialties. And in fact, when I was at Harvard, one of the things that we did in one of our clinics, we actually had medical oncology there as well, because then they could be they were the person who, particularly for early stage prostate cancer,
Right.
where the options are, active surveillance or
Yep.
watchful waiting, which we can talk about, surgery, and it could be prostatectomy or brachytherapy, which is
Prostatectomy.
radioactive seeds implanted or external beam. You have all these options. None of them include medical oncology. So it's really cool to have someone who is kind of like a neutral person to say, here's my opinion, and here are your options, versus having a surgeon who, patients may say, oh, well, they're going to be biased, or the radiation oncologist, oh, they're going to be biased. Medical oncologist is not biased. And so
Right.
it was actually a really good clinic that we had when we had all three providers there, but that can be hard to organize. And so again, particularly if you're in the community where that's the majority of where cancer care happens, is in the community, not necessarily at a big comprehensive cancer center where those sorts of
Right.
multidisciplinary clinics can happen. It's
Right.
really important, if you have a cancer diagnosis, and particularly a prostate cancer diagnosis, that you see a surgeon and a radiation oncologist.
And why is it important?
Because there are options. To your point, not only are there options in terms of what treatment modalities may be best, depending on the stage, right? So the staging is really important.
Right.
But then you as a consumer, you as a patient, you as a wife of, a man who's been diagnosed with prostate cancer, you as the brother of a man who's been diagnosed, or you as a son of a man who's been diagnosed with prostate cancer, can go in and have all of the information you need. Because a surgeon can talk about the surgery. A surgeon should not be talking about radiation.
Right.
But that's an option. And so just the same way, I'm not going to talk to you about what a prostatectomy is, even though I'm a radiation oncologist. Do I understand what it is?
Prostatectomy is a surgical procedure where your prostate is removed.
I can talk about that, but that's not my purview, and I don't want to talk about the side effects because I'm not the one who's actually performing the surgery, but I can talk about the side effects of radiation, and I can talk about what the long-term sequelae, the long-term problems that may be associated with radiation therapy to that area may or may not be. And so that's the reason, so that you can have all of the information at your fingertips so that you can make a decision, and that's going to be the right decision for you and your family.
Right.
So this active surveillance, that's a little bit, well, it's not a little bit, that's unique in the world, in prostate cancer, right? And that is part of the reason that there is some debate, I think, over when to start screening people for prostate cancer, because the thing is that it is very common among men, period. And oftentimes it is very slow growing.
Just about
right?
every man, by the time they're age 75, will have some
You
form
can
of
find
prostate
some
cancer.
cancer cells in the
But
prostate, right?
it may never cause a problem.
Exactly. So the whole crux of the issue, where you get into all the debate about when to start screening and what to do and all of these things,
Right.
is that you don't necessarily want to cause all of the side effects that a man can have from getting treated for something that is not going to ever give him a problem, quote unquote.
Right.
And so that is another big part of treatment for prostate cancer, screening, and all of this.
Yes.
So active surveillance, what is it? What does it mean? Who wants to take it? Or I can.
What is what?
So when a patient has active surveillance, these are people who were diagnosed with prostate cancer that is determined to be one of the slow growing, least aggressive cancers, right? That may not necessarily go on to cause problems. And so instead of going right away into surgery, radiation, or all the things that we're talking about, they might actually be watched actively.
Right. And with active surveillance. So we just said, I don't want to confuse anybody. So we just said that just about every man will probably have some form of prostate cancer by the time they're age 75. The problem is that Black men tend to have an aggressive form and are diagnosed a little bit earlier.
Yes.
And we don't have really the information in trials to know how their particular disease will behave.
Yes.
And so with active surveillance, that's where you're getting blood tests, or you may be getting, physical exams and you're being monitored every so often with PSA levels, and you're looking at maybe the rise of the PSA over
Mhm.
time.
Mhm.
Um,
Mhm.
you are being followed, but you
Mhm.
may not be intervened upon.
And an important and critical component of active surveillance is biopsy,
Yes.
rebiopsy, at least annually.
Every year.
So,
Yep.
so every 6 months there should be a PSA, at least every 6 months, to look at the doubling rate or how quickly the PSA test that level is rising, and a
Mhm.
biopsy is done every year. So that's some,
Yep.
it's an intervention in some ways. It's a procedure,
Right.
and so that's important to keep in mind. And again, I think that the challenges are there side effects with surgery? Yes, right? So there can be side effects with surgery. Are there side effects with radiation? Yes, there can be side effects from radiation. It may really be important for a man, particularly if you say you're age 60 or whatever, and you have a very slow growing, what appears to be a slow growing cancer, and you may say, oh, I don't want to deal with all that right now. My daughter's getting married next month, or, in 6 months or whatever. That may be an option for you, but again, particularly for Black men, we cannot sleep on this because we
Right.
don't have all of the data we need because we haven't
Right.
been in
We
all the
haven't been
clinical
a part of the
trials.
trials.
But
And
okay, so here's
it's
the
so
clinical
important to
trial
get
point.
your PSA early, because
Yes,
Yeah.
there are
We
other
have a
things
baseline. Yep.
that can elevate your PSA. And
yes.
one
Correct.
thing that a lot of people, I was just going to throw this little plug in really
Mm,
fast, was, you know, um, PSA is prostate specific. It's not always cancer specific. So
mhm.
if you get your PSA
Very good point.
earlier, you're less likely to have some of the things that can elevate the PSA. So sometimes there's something
Mhm.
called BPH, which is a benign tumor of the prostate. They can elevate your PSA levels. Another thing that's important that a lot of people don't know, if you are just getting your PSA level checked, you probably want to avoid having sex for about 2 days
There you
Yes.
go.
before that
Yes.
PSA is drawn.
Yep.
You
Mhm.
also do not want your doctor to do a digital rectal exam with the gloved finger before your PSA is checked, because that can elevate your PSA.
Yep.
The other
Riding a
thing,
bike, riding a horse.
Yep. Trauma.
rectal trauma, and however you want to think about that, can
Mhm.
elevate the PSA. If you have infection, that can elevate the PSA.
Yes.
Yes.
So know before you get your PSA drawn that you're in the most ideal
Mhm.
um, situation.
Right. So one of the things that I say is if a gentleman goes and has a PSA drawn and it appears to be a little elevator borderline, get another one checked, right? Because again,
Yes.
there can be something like that that has happened that may
Right.
artificially elevate. But again,
Right. And
importance of
try to
having a
get it done at
baseline.
the same lab.
Yeah.
Try to get it done at the same lab. Don't go all over town getting your PSA.
Yes.
Try to
Go
get
to
it
the
done
same
at the same
doctor.
lab. Yep.
Hmm.
Yep.
Hmm.
There's
Yep.
actually a pretty good question. My sister-in-law had a question that I thought was really
Okay.
good.
Hmm.
She says, with COVID, how can you ensure the team will come together to advise you regarding prostate cancer?
Hmm.
And I thought that was a good question.
Hmm.
Oh, so I'll answer it for you, Ebony. So, so you know, I am a community physician, so I'm a little bit different than how Karen practices. So really, in the community, we actually do a pretty good job of talking to each other, but sometimes you may have to be your own advocate. So
Hmm.
when you go to the urologist,
Mhm.
you say, you know what, I am also going to a radiation doctor. And once you've had discussions with both,
Hmm.
you may have them talk. If they're not willing to talk, you know just say, what you can even ask a urologist, what should I ask the radiation doctor?
Yes. Yes.
you know
That was going to be my
Yep.
thought, is
yeah.
actually because again, the gateway for prostate cancer is the urologist. That's the surgeon, right? So
Right.
if you go to your primary care doctor and you get screened, whether it be through the digital rectal exam or the PSA or both, and there's an abnormality that's found, elevated PSA, nodule on the prostate, your primary care doctor is going to send you to a urologist, because the urologist is
Right.
one who's going to do the procedure, the biopsy, that's going to
Right.
test the prostate to see if there's any cancer in that. So the urologist in many ways is the gateway. This is why the information about saying if you have a diagnosis of prostate cancer, please make sure when you talk to the surgeon that you also say, is there a radiation oncologist you would recommend? And perhaps they have somebody that they already work closely with,
Right.
right? That they can then say, oh yeah, why don't you go and see Dr. So-and-so? good doctors are always going to say, get a second opinion.
Yes.
Always.
And
They're
if
never going to be pissed off.
Yes.
You know,
Never.
they're never going to be they're never going to be angry. And so again, it's okay to say, is there a radiation oncologist you would recommend I see? And if they say no, it's like, okay, well, I'm going to go ahead and do that. Would you mind making sure that they get my information? And you're done.
Yes, that's very good advice.
Yeah.
Very, very good advice.
Tiff, you've been quiet.
Well, I had some. You were about to. We've been talking and weaving so long. That's a good thing.
Bobbing and weaving. We've been bobbing and weaving.
But we were talking about active surveillance and we kind of got back into clinical trials. But it was interesting because I just saw a newer study that came out recently out of Seattle, right, about active surveillance and Black men, and if it is a viable option, because there has been a lot of speculation and nervousness that it's actually not a good option for Black men. But at least in this study, the Black men that they had on their study, and I think it was like 80 something men, it looked to be a safe and viable option.
Yeah.
So it's important, not just, for the...
And so some of this depends on your risk, right?
But also it helps us know about the natural course and whether or not, Black men could be spared in some instances, some of these side effects, right?
Right. So when this
is very important.
When we think about prostate cancer too, one of the reasons why you want to always know your you want to know your PSA number like you know your social security number, right? You want to know what your PSA levels are.
Wow.
You also, and honestly, you do. You need to know your PSA number. Like, this is important. You also, there are risk categories, right? So there are some men who active surveillance may not be an option for them.
Right.
Sure.
Right.
Yeah,
because it really depends on your risk category. So if you have a diagnosis of prostate cancer, one of the reasons why you may, get surgery versus radiation, and the doctor may say, you know what, I don't think active surveillance is a good idea for you. That may have a lot to do with your risk category.
And it's related to that Gleason score. So Dr. Lamar mentioned the Gleason score, which is essentially looking at what the prostate cancer looks like under the microscope and how aggressive it looks. And anything, definitely if it's a Gleason 6 or below, and if it's only very localized, low PSA score, meaning, less than 10.
Localized means just in that area.
Yep. And if the PSA is less than 10, and then potentially you could be a candidate for it. And a lot of people don't want to do that. They just want to get something done, right? And that's fine too. It's an option for you to think about watchful waiting or active surveillance is the other term for it. And to your point, Tiff, I was looking at, so many of my early publications were actually in prostate cancer. So I was doing a lot of research at the time looking at risks to Black men related even to treatments. So this is again why we need to be included in some of these clinical trials. So abiraterone, right? Y'all know that, right? So we talk about hormonal therapy. So men have hormones too, the same way that women do. So don't get it twisted, y'all. Don't act like women are ones are hormonal. Y'all got hormones too. So hormones are the things that help our organs and our glands to function properly. And so the male hormone testosterone, many of you know, it's an important one. But the prostate cancers can sometimes be driven by testosterone. And so there are medicines that are used that actually can help to cut off
they manipulate
the signal.
The body.
Exactly. So sometimes that's called androgen, because androgen is the type of hormone deprivation therapy. So one of the things that I wrote a paper about.
We also call that ADT.
Yep.
If you see that online, ADT, like the security company.
I was going to say not the security.
Wow.
Okay. Well, that's how you remember it. Jackie Gleason for your score.
Wow.
ADT for your androgen. Hey, this is how you remember these things.
Yeah. That's good.
Gleason, you'll remember the Gleason score.
One of the important things to remember, again, because oftentimes Black men present with more advanced disease, and oftentimes in advanced disease, one of the treatments is going to be part of the treatment is going to be androgen deprivation therapy, or ADT. And one of the things that my colleague and I, who's a cardiologist, actually wrote a paper on is the fact that oftentimes Black men who are put on androgen deprivation may have higher risk of developing metabolic syndrome, so diabetes, obesity, and other things.
It's a big deal.
So again, these new medications that are coming out that are like, oh, this is all safe for everybody. Well, we don't know that. That's why we need to be included in these studies. That's why I encourage Black men to look for these studies. There's an amazing national organization called the Prostate Health Education Network, or PHEN, P-H-E-N. And it was started by my good friend Tom Farrington, who's Boston. He's a survivor. And he was like, I am not going to have my Black men continue to die like this from a disease that I know is treatable. And he wanted to use his own experience. And there is so much information on his webpage. So look up PHEN TV, and there are so many important pieces of information on there that talk about clinical trials. You may be able to find clinical trials that are there, but I know I personally gave a talk for them about the importance of clinical trials and Black men enrolling in clinical trials. But part of the challenge is, again, we talked about this in another one of our podcasts, that oftentimes Black individuals will have higher rates of heart disease or diabetes at the onset. So that may be discouraging when they say, okay, they raise their hand and say, I'm interested in a clinical trial, but then they're told they're not eligible because they have diabetes. And this is the thing, and that's on us. That's the institutional barrier. Remember, you're talking about some of the, there are the personal and community barriers. That's an institutional barrier that we are working on at the national level. I can, I could go on and on about some of the work I'm doing around changing the way clinical trials are done so that we can be inclusive. Because again, if we're doing all this effort to get Black men and women to say, yes, I'm going to enroll in a clinical trial, but then they get there and you're told, oh, you're not eligible because you have, high blood pressure. It's like, so what? Like, so does half the nation.
You know what? That's an important piece of it, because whenever we get into talking about participation in clinical trials, we always tend to focus on how the patient doesn't want to participate. That's a problem. We all know it. But to your point, as someone who's doing clinical trials, and for me, someone who's written them too, we all have written them. You've got to write inclusion and exclusion criteria. And when it comes to who's excluded from the trials, oftentimes it's people that already have illness.
Yes. Okay? It was funny because one of the most recent clinical trials that I wrote was actually using a template from an organization, and they wanted me to help run their clinical trial. They had the exclusion criteria as a BMI greater than 25.
Yeah, see, that's ridiculous.
Right? Like, so body mass index greater than, so first of all, again, we had this conversation about obesity, knowing that the majority of individuals, particularly those who are Black and brown individuals, are obese or overweight.
One day we're going to have a talk about BMI chart.
And exclusion criteria for clinical trials. That just means that you're not allowed on the trial if you have this parameter or higher. Right.
Yeah. All right. So we only have a few minutes left.
We have a few minutes. I was about to say, we got a few minutes left. What do you want to talk about? What you want to get out there?
I guess I would just want to make sure, to summarize what we've talked about, make sure people can go home. Like, what are our take-home points?
All right, so start the conversation at 40.
40.
Okay, if you're Black, start conversation at 40. That's right. Know your family.
PSA at 40.
Know your family history.
Right.
Please, let's start talking about what people have in our families. Let's not make it a taboo subject. Yes. I've had patients that were on active treatment whose families didn't even know they had cancer.
Right.
Didn't know what they were coming, to the hospital every 3 weeks for. So, it's so important to just start talking to our families, making sure we know, making sure we know what grandpa died of, what he really had, those sorts of things, because those factor into it too. And your family history factors into when you should start getting your PSA, your race, all of these things. So that's not a prostate thing. That's cancer health medical, right?
But because Black men are dying of prostate cancer, because Black men are dying of prostate cancer, and we're having a discussion about prostate cancer, please, Black men, know your history. Know if you have a brother who has a prostate cancer diagnosis, or a father or an uncle. That's really important. And the other thing that's important for today, I want to say that if you get a prostate cancer diagnosis, please get a second opinion. It's okay. There's enough time. And so whether it be, you might be comfortable with your surgeon, you might not need to get a second surgical opinion, but at least make sure you see a radiation oncologist as well, particularly if they say you have early stage prostate cancer. And I think that's an important thing that we've got to, if they're going to cut out your prostate, you need to actually see a radiation oncologist. Doesn't matter. If they say you have disease that's spread outside of the prostate and that they're just going to send you to a medical oncologist, that's fine. But if they're talking about doing surgery to your prostate, then you need to see a radiation oncologist as well. All right. And I think that's an important thing, because I've seen way too many Black men in particular who go and have a surgical procedure and the tumor was so big that they still needed to have radiation on top of it. So you're getting two treatments when you could have been treated with one treatment. Okay,
Mhm,
so that's an
mhm.
important thing. Getting a second opinion is important.
And if you have foregone all of our great advice about getting PSAs and haven't had one or something like that, if you're having urinary symptoms,
Mm.
difficulty urinating, frequent urination, getting up at night all the time,
Right.
pain with urination, all of those things, please get to the doctor and
Right.
have it checked out. Those are prostate symptoms. Doesn't mean you got
Blood
cancer.
in
Blood in the
bodily
urine.
fluids.
Yes.
Yes,
Pain.
yes,
Please don't
yes.
ignore that.
Please don't. Please don't.
Go
Yeah,
to
that's
the
that's really
doctor.
important. And
And
again, I'm going to throw my pitch in for clinical trials too. I know
yeah,
it's one of those things again that again if you have a prostate cancer diagnosis, and particularly those who may have more advanced disease where they're talking about chemotherapy. We didn't even get into that. We're not going to talk about treatments here,
yeah.
but if you do get a diagnosis and it's not a bad thing to ask. Say, is there a clinical trial I should consider for my disease? I think that that's something to just bring up as well.
Um,
It,
we have 5 minutes. Go ahead. Go
I was
ahead.
about to say, and if you have prostate cancer and maybe you're on treatment now, or maybe, you've had surgery or radiation, what can you do to help maybe decrease the risk of it coming back? Honestly, Tiffany, it goes back into your wheelhouse.
Y'all left me
Um,
4 minutes, but that's fine. I see how y'all want to be. That's fine. Looky here. The
Don't
one thing,
smoke.
the
Don't
one
smoke.
thing, the one
don't
thing I do want
smoke.
to leave you with is remember this is over 97% of men are alive at 5 years when you catch this early. So again, don't think of it as a death sentence. Don't think of it as, I'm so paralyzed. I don't want to deal with this. Like if we catch it early, the chances are greatly in your favor that you will treat it and you will go on about your business and live your life. And so
And and
that's why I want
and
to treat it early.
honestly, even in
Now,
advanced disease, our
yes, you
treatments
still
have
live.
improved
Yes.
in
Yeah.
my oncology lifetime.
Me too.
Yeah.
I mean,
Exactly. And we're about the
abiraterone
same. Yep.
was a
Yes.
Game
new
changer.
drug
Yes.
when,
Yes.
early on, and now it's one of the older ones.
And so they left me 3 minutes to talk about lifestyle.
Yes.
And what y'all wrong. I'm
Wait,
gonna
that
have
was
my day.
purposeful. That was
So
purposeful. See
first
that?
of
Go
all,
ahead,
okay,
see.
number one, you can have our podcast if you liked us or you didn't. Tell a friend and maybe they'll like us. We have a podcast.
Wow.
Wherever you get your podcast, you can go to your smartphone, look for Three Black Docs, whatever app you use for your podcast. We're there. I think we have like 8 episodes now. They're kind of like this. We just get together on a Friday because we're crazy and think it's fun to talk about cancer on Friday nights.
I'm sorry. Our last
during the
one on colonoscopy
coronavirus
was
pandemic.
funny. Our last one on colonoscopy was very funny. So
if you liked it, look for us. Subscribe to the podcast. Like I said, if you didn't tell a friend, they might like us. Everything isn't for everybody, but whatever. And so look, with the last 2 minutes, we want to talk about thanks, Ash. Lifestyle. What do we know is associated with more aggressive prostate cancer? Obesity, ta-da, smoking, ta-da, lack of fruits and veggies, ta-da. There's some noise in prostate cancer about lycopene, tomatoes, cooked tomato products,
Noise.
sulfurane
Yeah.
compounds,
Yeah.
broccoli, cauliflower,
noise.
dairy. There's some stuff about maybe dairy, maybe not, increased calcium, maybe. But the two biggest things, obesity, smoking for aggressive
Right.
prostate cancer, right?
Yes. Don't listen
Right.
to any of that stuff.
Stop.
Obesity, smoking, eat more plants and less animal fats and meats.
But you can have bacon.
You can have bacon sparingly, and I'm going to issue a challenge, Dr. Karen, this week
No.
for you.
No.
The challenge is eat a plant in every meal.
Oh, that I can do.
Oh, that's not bad. Oh, I thought you were coming with that
salad
one,
for
Tiffany. That
breakfast.
wasn't
Oh, no,
bad.
that's easy. That's easy. I got
I'm going to
that.
give you till Monday. So this weekend, you can think about what you're going to get from the store. And the challenge to next week from Monday to Friday is going to be eat a plant
Fine.
with every meal, and fruit juice doesn't count.
That's fine. I usually actually have plants for every meal. The one that I
Good.
don't sometimes is breakfast, but I actually had a salad for breakfast the other day. And it was good,
Get you
so.
some
Right.
berries.
No, I don't do that. That's not keto.
Watermelon.
And
Berries
so
are not-
our challenge
watermelon's not
for
keto.
the audience, one, if you know someone who needs their PSA, if they need to go to the doctor, please encourage them. The other thing is to get to know your family. You
Please.
have to sit and talk, get everybody together, and know your family medical history.
And now we live so spread out. If something happens to somebody, get on a Zoom call or whatever it is we're doing these days, and make sure that the family who lives across the country from you knows what's going on too. All
Yes,
right.
Please, please, please.
All right, y'all. That's our hour. That flew by as per usual.
Yeah.
Good to see y'all. It's our usual Friday. Next week, a plant per meal challenge.
All right. Sounds good.
All right.
Bye, guys. Thanks for listening.
We'll see you in a month for the
Take
next
care.
live. Don't know what it'll be yet, but see you next month.